Severe acute respiratory syndrome is a viral respiratory illness caused by the coronavirus. Coronavirus is thought to be transmitted most readily by respiratory droplets produced when an infected person coughs or sneezes. In 2003, the virus, which had originated from China, spread to over 37 countries. An example of a lesson learned from the SARS outbreak was the importance of data sharing and reporting across borders. A lesson observed was the importance of international collaboration, and a lesson lost was data collection methods and sharing.
This Ebola virus.
According to the CDC, Ebola virus disease was discovered in 1976 in the Democratic Republic of Congo, where the first outbreak had occurred. Bats are hypothesized to be reservoirs of which the virus can be spread to other animals as well as humans. Humans can spread the Ebola virus through direct contact with blood, urine, sweat, saliva, vomit, and semen of a person who has had Ebola, objects that have been contaminated with the virus, such as needles or syringes, or contact or ingestion of an infected fruit bat or animal that has had the Ebola virus. 2014 to 2016 marked the worst Ebola outbreak in history, where the CDC called a level 3 warning to avoid non-essential travel in West Africa. Unlike the 1976 outbreak, the recent outbreak had affected rural and major cities. West African countries were ill-prepared of the advancement of the Ebola virus for multiple reasons, such as population mobility, a poorly equipped healthcare system, cultural and religious practices, an overwhelming amount of additional infectious diseases, absence of preparedness, and infrastructure constraints. Two key lessons learned from the SARS outbreak can be reflected upon the Ebola outbreak. One issue is a lack of epidemiological data. This led government officials to work towards an improved surveillance, laboratory, and incident management system to collect and analyze data. A second issue was a lack of collaboration and partnerships within international, local, and government organizations. This was improved in 2014 when the CDC helped to set up a National Emergency Operations Center. Throughout the recent outbreak, there were similar problems that would repeatedly occur as found within the SARS outbreak. Some of these observed lessons were the importance of primary prevention, which is necessary to handle future outbreaks. This can range from creating prediction models, response, and control mechanisms, strengthened international cooperation and coordination, lack of local buy-in. This limited the aid the national and international authorities were able to provide. More social behavioral research and community building is needed to understand the limitations for providing care in these regions. Lack of emergency preparedness and control procedures in relation to staff. There was a limited Ebola training and handling sessions for healthcare workers and cleaners. Additionally, there was a shortage of personal protective equipment for healthcare workers. Many field workers did not have any of this equipment, which led to a high death rate in healthcare staff. Lessons lost were lack of acknowledgement of traditional and religious practices in handling Ebola. Healthcare staff poorly considered cultural practices. Instead, their priority was safely disposing infected bodies. Poor data collection methods were utilized, as the previous referenced 1976 data collection methods were unsuitable for the large-scale recent epidemic. Patient data cannot be registered because they were turned away due to the maximum capacity levels being reached in treatment centers.